Let's begin. Okay, just as a disclosure, just to call these out. So I'm supported by foundation, government in Canada and China, and I work with multiple pharmaceutical companies, largely as a consultant. A bit more about me, I spend a great deal of my time in drug discovery, in drug development. I'm both a psychiatrist, I'm also a pharmacologist, and my lab in Toronto is in partnership with many organizations repurposing agents for depression and bipolar disorder, and as well we are developing very novel treatments and work with these organizations. One of the key points that we had in the previous iteration was the emphasis on screening and diagnosis of bipolar disorder. 2019, I was going to say 2020, but it's almost 2020. 2019, the unmet need in bipolar disorder has to still start with timely and accurate diagnosis. And I emphasize both timeliness and the accuracy. This was the field trial results from the DSM 5.0. To benchmark this, kappa correlation coefficients at 0.4 are considered minimally acceptable. And for bipolar 1 disorder, bipolar 2 disorder, we're coming in at 0.56, 0.40. So bipolar 2 disorder just making that cut at 0.40. By the way, major depressive disorder comes in at about 0.28. I've got a bit of a typo here for some reason. Anyhow, the focus is on bipolar 1, bipolar 2 disorder. And the rates continue to be reported that we are in fact still in a situation where the great majority of individuals with bipolar disorder are not diagnosed timely. And part of this is the predominance of depression, depressive symptoms and episodes. And that is, I think, one of the key calls to action with respect to our guidelines in terms of the screening process. Just to fill that in, by the way, there was a report that came from the DBSA, what was not called the DBSA at the time, now it's called the DBSA, the Depression Bipolar Support Alliance, that the modal adult with bipolar disorder comes in contact with 3 to 4 specialists before he or she is receiving the diagnosis of bipolar disorder, spanning 7 to 10 years. And we still don't have evidence that that report card's any better today. The part that makes this tricky, and I think every clinician here knows this, is that depression is often the index presentation of bipolarity. So you cannot provide the diagnosis of bipolar disorder without hypomania or mania. And there's a transition, there's a conversion process, and it's a fairly consistent conversion rate reported at about 1 to 2% per year of prospective follow-up. So 2 points, one being that the requirement for screening for bipolar disorder, not just at the initial presentation, but at subsequent presentations, especially when treatment outcomes are not favorable. This was a report that was out of Taiwan, and the theme is probability factors. So the patient who is in the healthcare setting, typically with a confluence of depressive and anxiety-related symptoms, does not have any symptom that is pathognomonic of bipolar disorder. The individual's in the office with typically syndromal depression, and the challenge for the clinician is to identify factors that increase or decrease the probability the likelihood this person has bipolar disorder. And this report, which was a pharmacoepidemiologic study from Taiwan, demonstrated that the probability of having a diagnosis of bipolar disorder in an adult with depressive symptoms increases as a function of the number of prior antidepressant inadequate outcomes. Now they had this language, easy to treat, intermediate, difficult to treat. This can be simplified. Patients improved with one antidepressant, required at least 2 antidepressants, needed 3 or more antidepressants, and that has been replicated elsewhere. So for us, when we're talking about managing bipolar disorder, timely and accurate diagnosis, it's still the case that age at onset, number of episodes, to some extent phenomenology, to a greater extent family history, are able to guide the clinician towards or await a diagnosis of bipolar disorder, this part being the number of prior antidepressants. And related to this is the emergence of hypomanic symptoms in a depressive episode temporally associated with antidepressant exposure. So in the previous DSM, if hypomania was associated with antidepressant exposure, it did not count towards a diagnosis of bipolar. If the patient does have the emergence or amplification of hypomania during a depressive episode with antidepressants, that does count towards a diagnosis of bipolar. That's often a very good suggestion. Now, this is in fact a look at the mood disorder questionnaire. The 2 most studied, reported, validated, multi-language, multicultural, multi-nation, is the mood disorder questionnaire and the hypomania checklist. I think most would know the MDQ. The hypomania checklist is not as well known in North America. Outside the shores of North America, it has better brand name recognition, so to speak. Just a reminder, I know it's early Saturday morning here, MDQ, Mood Disorder Questionnaire, we've had it for almost 2 decades. 13 items, self-administered. 7 or more of these items scored yes, positive, occurring at about the same time with functional impairment. The MDQ has modest sensitivity. It depends on the environment you're in. If it's a specialty mood center, a primary care center, or in the community, in the general population, the batting average comes in on sensitivity around 70%. The batting average on specificity comes in at about 90% with variable results. So a screen negative, you've got confidence that the person probably does not have bipolar disorder. A screen positive means you've got more work to do. This was, I thought, an interesting analysis. This was recently reported where these investigators, this is from Brown up in Rhode Island, they just took a couple of items actually from the MDQ, tried to narrow the MDQ into 3 items, the MDQ 3, I guess, and the effort was not just to shorten and create this wiki version of MDQ, but to try and provide a tool that could sufficiently disambiguate bipolar disorder from borderline personality disorder, which many clinicians lament is too often being labeled as bipolar disorder. And they had some interesting statistics, and this briefer version, in fact, performed reasonably well with respect to, and the 3 items were elated mood, increase in activity, and functional impairment. I was a bit surprised that was enough to do it, but it was what it was. Just as a sort of parenthetical comment in something that I'm working on right now with a small working group here in the US, is to develop another screening tool for bipolar. Now, there's a couple of reasons why we're developing a new screening tool for bipolar. First is that I had been very generous in describing the sensitivity and specificity of this particular tool, but other people are reporting much less favorable sensitivity and specificity of the MDQ. And one observation that is shared by many people in this business of bipolar disorder is we are seeing fewer and fewer individuals with bipolar who present with elated mania. And we're seeing more people with mixed mania. And I think people's heads are nodding. It's a global phenomenon. And I often facetiously say a lot of people went into psychiatry because of elated bipolar disorder. you know, and where have all these grandiose patients gone? But the point I'm getting at is the items on the MDQ disproportionately are asking about elation and less about mixed. And so that's a question that's been raised. Another point I wanted to bring up is the topic of cognition. Now, I'm always thinking about, is this going to change our recommendations? But there may be some, particularly in light of our talk last night, there may be some aspects around prevention of cognition. So this is global cognition in bipolar I disorder. Cognition in bipolar would be similar to schizophrenia insofar as it's core, it's pervasive, it is progressive, it is a mediator of health outcome, fairly replicated finding of profound cognitive impairment across all the atoms of cognition. Academic questions are, which one has more cognitive impairment, bipolar I versus bipolar II? That's a bit academic, won't change what we're going to do here today, but it's an interesting question. To answer that question, we don't know. But once you adjust for psychosis, the cognitive impairment reported in bipolar I and bipolar II are less really different. In other words, there seems to be minimal difference between BP1 and BP2 after you adjust for psychosis. But I think to keep this to the point of today's exercise is that we don't have an FDA-approved agent for cognition in bipolar disorder. For your interest, this is an area that's very active with many different approaches being looked at in the technology area, device area, psychosocial area, also in pharmacologic interventions. So, and clearly a significant problem for these patients. The two enemies of the state in bipolar disorder are depressive symptoms and cognition. I think this is relevant on many levels, but to keep it succinct, from the point of view of screening and the want that we have for clinicians to be contemplative of bipolar. There's still good reasons to believe that clinicians are often pre-contemplative of bipolar disorder, perhaps in part because of the predominance of depressive symptom presentation. There's been about a dozen studies now published that are the so-called symptom structure analysis, breaking down the symptoms of bipolar weekly, monthly, longitudinally, and each study reports out the same thing. This is a depressive, anxious, dysphoric illness rather than an elated mania type illness. This is a paper which we hope will be in press very soon. It's kind of a State of the Union in bipolar. It's going to come out in Lancet. And why I've brought this in is because this topic of diagnosis, screening and getting this done accurately, and the topic of mixed features. And we have a special section in our guidelines on mixed, and there's no question that this is common. I think I have a slide to follow up on that. But the screening and diagnosis piece is so critical here, and I think this sends people really astray. So the patient comes into the clinics, the patient's depressed. I call this the 5 A's. The patient's anxious, they're anhedonic, they're agitated, they're having attentional problems, distracted, and very irritable and anger, lots of anger. Anyway, this was just more of a kind of a bit of a way to kind of make this very user-friendly for clinicians and so on. But the point is, we want people to be thinking about mixed. And when they see individuals who are depressed, especially when they have mixed features, that's the clarion call for screening for bipolar. It also has relevance. It's not just an academic exercise. Where there is a consensus in the area of bipolar disorder is the adult with bipolar 1 or 2 who has a depressive episode, who is experiencing intra-depressive episode hypomanic symptoms. That is, they may meet the criteria for mixed feature specifier, that individual should not be prescribed an antidepressant. There's consensus on that. And we're going to get into antidepressants in just a moment, and we're still, in fact, not entirely in a consensus as to who should get antidepressants in bipolar, but we've got consensus who shouldn't. And that's the person who's rapid cycling, the person who, in fact, is bipolar 1 disorder and not taking an agent that's mood stabilizing, and the person who has mixed features, either organic mixed features and or induced by antidepressants. This was just to put some data around this. Mixed features that comport with the DSM-5 criteria, the mixed features specifier, affects about 1/3 of adults who have BP1, BP2 during a depressive episode. A little later on, we're going to talk about major depression, not too far behind. That group has got a lot of mixed features as well. Okay, so keep going. Let's talk about suicidality. This is looking at suicidality. This is from a European study. It may not surprise anybody that depressive episodes, that suicide is more reported in depression. What this is missing is important granularity. I don't think this is really the zinger. I think you would have guessed that before you even were in this area. I think anyone would guess that. I think what's really the zinger, I think, is the mixed features. And so within depression, this is a heterogeneous group, patients presenting with a depressive episode. The call to action is all patients need to be asked about suicidality, not just ideation, but of course plans, attempts, and especially people who have mixed features. That group especially is impulsive, is dysphoric, and so much of suicide completion is an impulsive event. To keep going, this is really not departing the topic of depression and suicide, but is now bringing the topic up of physical health, so below the neck. This is obviously very concerning, and I react when I see these reports come out how mortality is decreasing from diabetes. Mortality is decreasing from select non-communicable diseases, some forms of cancer, and then I see that, and I think we are going in the wrong direction. So mortality is not going down in bipolar disorder, broadly, and if these results are accurate, it's going in the wrong direction here. That's driven largely by cardiovascular disease. I don't have the slide with me, but the cardiovascular risk in bipolar disorder is significant. About 3 years ago, we published a paper on behalf of the American Heart Association where bipolar disorder is a tier 2 risk factor for cardiovascular disease. And a colleague of mine in Toronto who studies pediatric bipolar disorder has shown in his lab that adolescents with bipolar disorder begin to show subclinical evidence of vascular disease. So this is very early on. And this will get into the physical health piece and below the neck management. To put some sort of numbers on this, about 50%, according to our data, of individuals with bipolar disorder have either the International Diabetes Federation or the NCAP definition of metabolic syndrome. Taken together, if you were to look at all mental disorders, perhaps schizophrenia slightly more, depends on the study. Maybe Christoph, you'll speak to that, I don't know. But certainly it's a kind of a race to the bottom. Schizophrenia and bipolar both are differentially affected by components of metabolic syndrome. And no question, part of this is iatrogenic, but that doesn't explain a lot of it. And one of the interesting pieces that's been now emerging is the effect of obesity in the bipolar population on measures of general cognition. I often state that obesity metastasizes to your brain. And what I mean by that metaphor is that through a host of effectors, obesity is decreasing cognitive performance in this group over, in addition to the disease-related aspects. And outside of this world of psychiatry, there's a very large literature in the obesity world where I spend a lot of my time speaking to the anti-cognitive effects of obesity. It's a very, very interesting and concerning relationship. But what I want to stay with is a couple of points. First is we're talking about managing below the neck as well as above the neck. And it's not only the case that obesity has implications for physical health and risk for other disease states, but there may also be implications for phenomenology. So this is in fact looking at, hang on, I thought I had this side of me. No. So this is looking at the effect on the illness trajectory in bipolar disorder, wherein obesity is, this has been replicated, not only linked to decreased treatment response in some studies in bipolar, more chronicity, more treatment resistance, but also perhaps shorter time and increased risk of relapse recurrence. But what's very interesting is, in addition to cognition impairment more likely in the obese subpopulation versus the normal weight subpopulation, there's a story unfolding that obesity and mixed features march in the same direction. So there's something of obesity that may be changing the phenotype of bipolar disorder towards a more mixed. So recently we published a paper where we kind of tongue-in-cheek said that the obesity epidemic is creating a mixed features epidemic. And there's a very interesting bi-directional relationship. When creating a slide on the unmet needs in bipolar, one can just go on and on and on. I mean, there's so many unmet needs in bipolar disorder. But I think for now I'm just going to leave it with the screening, timely and accurate diagnosis, major unmet needs clearly in the area of depression and cognitive impairment. But in a few moments we'll talk a bit more about some of these other aspects in terms of patient engagement, patient diagnostic and treatment literacy, patient family engagement or additional support engagement, and a whole host of unmet needs in the area of side effects. This was some data that we published. I'm a director of the Depression and Bipolar Support Alliance, and this is data from our one of our databases of individuals who are life-lived with bipolar disorder. And I don't think the results here are going to surprise many in terms of the factors that influence decisions, with side effects and physical health being so high on the list. The other part, in fact, being the impact of treatments on day-to-day function, which has been a tremendous unmet need for us in bipolar, not just, in fact, to provide treatments that are symptom suppressing. We can't say we have treatments that are affecting illness trajectory or progression. We don't have curative treatments yet. And I think really, in fact, where there's a real push now is treatments that are capable of assisting patients in the area of positive mental health. Positive mental health. The taketh away of psychopathology does not equal positive mental health, and this is something we still struggle with. Now let's talk about antidepressants. This had just was published a few years ago now, and as I said, antidepressants in bipolar disorder remains a fairly, there's still a lot of controversy with this. You all know that FDA has not approved any conventional antidepressant for bipolar depression, bipolar 1 or 2, acute or maintenance. And I'd mentioned earlier there is agreement in the field that patients who have mixed features, rapid cycling, bipolar 1 without mood stabilizer, or patients with history of destabilization on antidepressants would not be candidates. We agree on that. But when you actually look at what's there in terms of bipolar response and remission rates, we are getting some signal of antidepressant efficacy based on this meta-analysis on response above and remission below. This was a more recent summary of over 50 studies looking at this topic of treatment emergent mania. It certainly is the case that the reporting of treatment emergent mania on an antidepressant is more likely in an open label study than in a controlled study, but it certainly is described in controlled studies as well. And here are some of the predictors. So maybe in fact, as we're thinking about, because this is such a commonly asked question, which individual can be safely prescribed an antidepressant? And identifying what are the predictors of treatment emergent mania would alert the clinician. Many of these would not surprise people, the rapid cycling aspect particularly, but I think in fact what's to be emphasized in our guidelines is the need for concomitant mood stabilization, at least in bipolar 1 disorder. Bipolar 2 disorder is getting very, very tricky on this. And I think I have a slide on that. So these are factors that could potentially influence candidacy for antidepressant use in bipolar disorder. And so I've got favors antidepressant use, just to orient you, discourages antidepressant use. So I think I had the slide with me, but we now have several studies showing that the propensity for the induction of hypomania and or dysphoria and or destabilization is lower in BP2 than BP1. Secondly is, and this almost sounds like heresy to some people, but antidepressant monotherapy in bipolar 2 disorder has some lines of evidence supporting safety and efficacy. And that's really contradicting some of the thinking that many people have had for a long time. For patients who have stable episodic depression in the absence of hypomanic symptoms and cycling, they may be a candidate, and of course no recent mania, hypomania. Why that's there, by the way, just as a historical note, about 30 to 40% of people who have bipolar disorder have what's called MDI or DMI. That is, they have biphasic episodes of mania followed by depression, or depression followed by mania. And that's been described for hundreds of years, actually. And this is why when we give someone a treatment for mania and they become depressed, say 4 to 6 weeks later, you could not conclude that the antimanic treatment caused that depression unless you could show that signal over and above placebo. And similarly, for patients who are depressed, who receive antidepressant, if they become hypomanic or manic, you don't know if that's just a naturalistic switch or whether the drug did it. And this is why it's so important in placebo-controlled trials. In fact, we don't have a lot of placebo-controlled evidence that antidepressants are switching people into mania. Other factors here, no alcohol use. Alcohol seems to be, in drug abuse, is a probability factor for unfavorable antidepressant outcome. Prior favorable antidepressant response, and no history of treatment emergent affective switch. Where there is it's anemic is the long term. We just don't really have much in terms of long-term evidence that antidepressants are able to sustain wellness, sustain stability. The million-dollar question that comes up all the time is, how long should I keep the patient on the antidepressant for? And in 2019, November, we still do not have robust replicated evidence that long-term antidepressant exposure decreases episodes, hospitalizations, health outcome. Now, this is in fact based on up-to-date data, 2019, in the area of bipolar II disorder, we have NIH-sponsored studies showing that venlafaxine and fluoxetine may in fact be superior to lithium in bipolar II disorder, and if you can believe it, as monotherapy. And so these three, circulated in different studies also, this was a study that came out of the Stanley Consortium last year in the American Journal, in fact, that sertraline monotherapy in bipolar II disorder was safe and more effective than lithium in bipolar II depression. And so that's fairly new data. And that really is getting in the way of the ideology that you cannot use antidepressants as monotherapy in bipolar disorder. This is monotherapeutic treatments in acute bipolar depression. And so this is up to date. Lithium, lamotrigine, erapizole, so a variety of agents have been looked at. The new one for us this year in the guidelines is going to be Chryprazine. I think it was May of this year, the FDA approved Chryprazine for acute bipolar depression. It's lots of negatives here, more negatives I think than positives. Lithium is negative in this large acute trial. We have other lines of evidence for lithium. Lamotrigine we had as a level 1 treatment before, and we discussed this a long time. That this is an interesting story. When the sponsor conducted studies with lamotrigine, they were all negative. The positive studies for lamotrigine were all done by academic groups, which is usually the other way around. You know? It's usually the other way around. Olanzapine cynically was positive because the study was so hugely sampled. The effect size was very small. That's why fluoxetine was added to it. Quetiapine is very positive. The cynic would say, well, isn't there functional unblinding in these studies when you're giving patients 600 milligrams of Seroquel? Do you not know they're on the drug? Do you really believe they're on placebo? And if you think they're on placebo, you probably should have your license taken away. That's what people often say. Lorazepam we've had, of course, and now Chryprazine. This is the combination studies. I won't go through each one of them. Really, when it comes to positive, we really just have lorazepam and olanzapine fluoxetine combination in acute bipolar depression. This is a newer update for us this year, Chryprazine, and its FDA approval May of this year in acute bipolar I depression. And the dosing is here 1.5 and 3 milligrams. This is a dopamine partial agonist. And at the lower doses, there's some PET evidence that would indicate in vivo that it has selectivity for the D3 receptor. So slightly different, at least based on some preliminary work, than aripiprazole and brexpiprazole, with some decent response and remission rates in the area of bipolar I depression. We've had Chryprazine in acute mania, where it was indicated back in 2015, so there's been an update to that. Just a couple of points. I think we have some new folks on our panel this year. If there were so many negative studies with lamotrigine, why in fact did it get such a high rating? Well, there's other positive studies conducted by academic groups where it's been particularly effective in acute bipolar depression as well as recurrence prevention. And it's turned out that there was a number of methodological aspects that we learned were likely diluting the acute antidepressant effects that were observed in the original sponsored studies. If anything, the development of lamotrigine did more for guiding how to conduct studies in bipolar depression than it did for actually lamotrigine. And this is just showing how the baseline severity affected placebo responses in these studies. Lithium still remains the only anti-suicide agent in bipolar disorder. And clozapine for schizophrenia, lithium for bipolar, other anticonvulsants, atypicals, we don't yet have replicated. And this seems to be something so far unique to lithium. You know that story. On a separate note, lithium seems to decrease the risk for Alzheimer's disease in this population. Perhaps a further emphasis in or a newer update is here. The approval of the long-acting injectable erapizole for bipolar maintenance. And this has been an updated approval to the FDA gave the company who markets this product. And I would say that in my experience in this area for many, many years, I wouldn't have guessed 20 years ago that the type of people with bipolar disorder that I have on LAIs are some of the people I currently have on LAIs. And what I mean by that is I've got professionals. I've got executives, I've got lawyers who are taking LAIs. And I think the prototype, the person we're thinking about for LAIs, the non-adherent, often tertiary patient, that patient still is clearly a candidate, but I've been really quite struck at how often people with bipolar disorder who are much higher functioning say to me, I prefer to make one choice a month than 30 choices a month. And so this has demonstrated antimanic effect. The way the trial was designed, it didn't allow us to ascertain whether there was a beneficial effect on depression. So the LAI aripiprazole is a new update the last year and a half, 2 years. We just don't know if it can forestall or prevent depression, but it certainly forestalls and prevents mania. And I don't see that as a treatment confined to the more tertiary patient. This was an interesting study in JAMA last year, 2018, from Finland. This was a pharmacoepidemiologic study looking at the prevention of hospitalization in adults who have bipolar disorder. And what particularly caught my eye, among other things, was yet again, lithium does especially well in the long-term recurrence prevention of bipolar. But what did especially well is LAIs. So risperidone long-acting injectable did particularly well here in this analysis, as did perfenazine. Now, I haven't prescribed perfenazine LAI in bipolar in a very long time. We don't prescribe many conventionals. But the point being is that we have this data showing reduction in hospitalization rates in bipolar in individuals taking LAIs. Now, ketamine, we'll talk about ketamine in a bit more detail this afternoon in depression, where the indication was given March of this year, the S-ketamine, the isomer. The racemic mixture of ketamine has been looked at plenty in major depression, but also some data now in bipolar depression, and maybe we can have that discussion because treatment-resistant depression is an adjective rather than a noun, and if we want to look at the nouns are often bipolar disorder. We should maybe have that discussion, I think, amongst the group. Just to wrap this up, non-pharmacologic interventions listed here. I'll put a plug in for advocacy. I don't recall we put as much emphasis on that before. Maybe we can talk about that. One of the questions that comes up, is there technology, are there apps that are now ready for us to really emphasize in the area? And I would say still, though, those are works in progress. Promising, but not prime time. I don't think we can we say we're going to recommend a specific technology there. And I don't think anyone's going to take issue with some of these other non-pharmacologic approaches. This is looking at the relapse prevention. I would not see psychosocial, manual-based psychotherapy for acute mania as the treatment of choice. For bipolar depression, there's less evidence acutely that CBT, mindfulness, IPT, social rhythm, family are acutely antidepressant, but there are data for that. Where the evidence for the adjunctive manual-based psychosocial interventions is most compelling is in the relapse prevention as the add-on to the pharmacotherapy. With respect to neurostimulation, ECT was certainly well represented in our previous guideline. There hasn't really been much work, frankly. This is a major gap in the field. ECT for bipolar depression, nothing's been new since our last meeting, and it still remains, by the way, our go-to for those very malignant bipolar depressions. We'll talk about TMS a bit later. More just topical issue keeps coming up, and is there a role for us recommending biota manipulators, pro antibiotics? I don't think we're there yet. This is always a question now that comes up given some of the interest in this topic, but when it comes to the management of bipolar disorder, I don't think we're quite there yet. I say that knowing that we've done meta-analysis, we've done studies looking at minocycline, one of the antibiotics, as being helpful in some adults with bipolar depression, but I don't think we're there yet.